Ready. Thank you.
Okay, good morning. We're going to get started. I want to be respectful of everybody's time. I know you have all stuff to do. We're going to start on time. So good afternoon. Thank you for coming. My name is Dr. Hans Stewissen. I'm the Ingalls Brown Chair of Anatomy and Distinguished University Professor and the Chair of the Department of Biomedical Sciences. And for the students in the room, that's most of your professors that you've seen in the first and second year are professors in that department. So it's my pleasure to welcome you to this Watanakunakorn Lecture. It's an annual event. And before I introduce Dr. Shenoy, I would like to take a moment to tell you how this lecture series came to be, and to express through that our gratitude for the family of Dr. Watanakunakorn for endowing it. So Dr. Watanakunakorn was a beloved professor of internal medicine at this university, and he was the director of infectious disease at St. Elizabeth Health Center in Youngstown until he passed in 2001. I actually knew him. And I will take the liberty now to tell you one little anecdote that shows you what kind of person that he was. The current laboratory manager in my department, her name is Sharon. She lived in New England 25 years ago, and then wanted to relocate to Northeast Ohio with her husband. So from New England, she was looking for jobs in this area, and she wrote a number of physicians and Ph.D.s in this area to see if there was a lab tech job available, because she was eager to have such a job when she would arrive. She wrote a bunch of people, and except for one, nobody wrote her back. This is, of course, before the time of email. The one person that did write her back was Dr. Watanakunakorn. He didn't have a job for her, but he felt that it a common decency to write back to such a person who wanted to work in this field and at this university. And he wanted to be as welcoming as it could be to people moving to this area. I find that pretty remarkable, because she was not somebody that he would ever expect to run into or ever see again. I think also remarkable is that his family in 2004, the Watanakunakorn family, made a gift to honor Dr. Watanakunakorn's passion for medicine and his profound contributions to medical education. They presented the NeoMed Foundation at that time with the largest charitable donation in its history at that time, $3 million. And in their honor, we renamed one of the buildings for the family. We also established a named endowed chair in his name. Currently, that's held by Dr. Ping Zheng, who's sitting over there. And we created an endowment for scholarships for our students. Those scholarships are allowing us to send students at NeoMed from any college to conferences and to pay them a stipend for time spent doing research in infectious disease, and provide them with some research funds for that. If you don't know what that's about and you are interested, you should talk to the people who run the infectious disease interest group in the College of Pharmacy and in the College of Medicine, or to its faculty guide, Dr. Feng Dong, who is sitting over there. So so that was the earlier donation. Then in 2015, Eleanor Watanakunakorn, the wife of Dr. Watanakunakorn, made an additional transformative gift to NeoMed. We named this auditorium in her name, and she also established the endowment for this annual lecture, enabling us to bring esteemed speakers like Dr. Shenoy to campus. So it's my pleasure to share that Eleanor Watanakunakorn and her son, Paul, who is an MD, graduating with an MD degree from this institution. They are virtually with us today, and so I would like to recognize them for their, to show our gratefulness to them. Okay, so that brings me to the introduction of today's speaker. Dr. Erica Shenoy went to college at Princeton and medical school at Harvard. Subsequent medical training and faculty appointment were at Massachusetts General in Boston, where she is now. She is the Chief of Infection Control for Mass General Brigham Healthcare System, where she's responsible for the development and the implementation of infection control strategies, policies, and their measurement. She's an associate professor of medicine at Harvard Medical School and an infectious disease physician at Massachusetts General. And then she's a fellow of the Infectious Disease Society of America and the Society for Healthcare Epidemiology of America. For the latter society, then, she's also an elected member of their board of trustees and the immediate past chair of their Public Policy and Government Affairs Committee. And she's a co-chair of the committee that develops guidelines for low-level disinfection practices. Dr. Shenoy has extensive experience both in the treatment and in research in infection prevention and control, including that during the COVID pandemic, and she's also very interested in hospital-acquired infections. Her research interests have resulted in nearly 100 published papers, many of them focusing on clinical decision-making processes and antimicrobial resistance. The title of her talk today is Infection Prevention in 2026, Essentials for the Practicing Physician. Dr. Shenoy.
Great. Just want to make sure you can hear me okay out there. Yes, thumbs up. Awesome. Thank you. Well, thank you for that wonderful introduction. I'm really pleased to be here to talk to you and about infection prevention in 2026. And my goal here is, I know that not all of you will go into infectious diseases, probably most of you if I do my job, but for all of you who go into medicine or pharmacy or dentistry, to think about infectious disease and infection prevention in all that you do. And I think it's going to make the care that you deliver so much better. And I hope I can prove that to you today. So I do want to thank the family for their vision and generosity, and the organizers of today's events for their invitation. I had heard of the Watanakunakorn family because every year at ID Week, which is where all the ID docs get together, there is a named award. And that award has so much meaning in the ID community because the people who get that award are like the ID docs. It's like the person you would go to. They're such like clinical experts. And so I'd heard the name, but what I didn't know until I read the flyer that went around is that he was actually the hospital epidemiologist at St. Elizabeth's. And I thought, oh, like that's my people. That's what I do. And so I started searching some of the literature to see what he had worked on while he was in that role. And the first thing I came across was this back and forth in our standard, the infection control journal out there. It's called Infection Control and Hospital Epidemiology. And this is dating back to the late 90s. So I dug a little deeper, and up on the top right, you're going to see his PubMed timeline. It's really extensive and really phenomenal, like close to 200 papers. And he did amazing research and published on so many issues that are still relevant, are very relevant today. So this was that paper looking at occupational health and screening of healthcare personnel. There was a paper that he did that was actually led by one of the medical school students looking at hand hygiene, looked at influenza vaccination and attitudes among healthcare personnel, and was really at the forefront of some of the earliest guidelines around antimicrobial resistance. And here he is as the senior author on the joint paper of the Society for Healthcare Epidemiology, that was mentioned before, and the Infectious Disease Society of America, putting out those first guidelines around antimicrobial resistance. So really, this opened up a whole new kind of perspective of me, of his influence in the field. So I'm going to go through three parts of the talk. And I want you to think about how you can see risk in the clinical arena that you choose to practice in. And I'm going to talk about 3 parts of risk or 3 areas of risk. One, our hands, and the subtitle, because this is an act, is it's me, I'm the problem, it's me. And I'll tell you why it's all of us who work in healthcare and the fact that we don't do hand hygiene when we should. So that's part 1. Part 2 is all about sinks and drains. And hopefully this morning you didn't wake up thinking that you would learn about infectious diseases and infection prevention when talking about the plumbing, but we're going to learn about that here today. And then lastly, it's the bigger picture, what's called the environment of care. And it's the environment in which you all are practicing, if you're already out there practicing, or you're going to be practicing in, and appreciating that while we are so focused on the patient in front of us, there's so much around us that is contributing to risk, and things that, very simple things that we can do to reduce the risk to the patients and to our colleagues and ourselves. So why should you even care about the things that I'm going to talk about? So if you've already committed to infectious diseases, I know there are some of you out there, this is a great choice. It is one of the most amazing disciplines in medicine, and infection prevention, which is a subspecialty of it, is even the best. So maybe some of you who were going into ID might think you might go further into infection control. The other part is if you go into infectious disease, or if you're a practicing ID doctor, to the outside world and even to your colleagues, they're synonymous with each other. And so it helps to know a little bit about infection control if you're in ID. For those of you who have not chosen ID yet, there's still time, just going to put that out there. But as I said before, if you don't choose ID, have an appreciation. I was talking to some of the students who are going to match in anesthesia, emergency medicine. ID's everywhere. It knows no borders. So having a familiarity, or at least an appreciation to say, okay, I know I should be thinking about that. I can always call an ID consultant for help. Will make you a better physician or pharmacist or dentist. Lastly, for everyone else, I hope that you will have some interesting tidbits that will make you the life of the party at your next social event. Okay. So there's one kind of heavy slide that's about a foundational concept in infection prevention, and then I'll get to all the pictures. So this is what's called the chain of infection. So the concept here is that for an infection to transmit from one patient to another, you only need 3 things. You need a reservoir. That's where the infectious agent is kind of living. You need a mode of transmission, and the mode I'm going to talk about mostly today is contact transmission. So contact, like direct contact from my hand to the patient, or indirect, my hand to the ultrasound to the next patient. And then you need to have a susceptible host. At any point in this chain of infection, if you intervene, you can stop infection from being transmitted. So in the example, let's say a Staph aureus. So Staph aureus is on the skin of the patient I'm seeing. My hands get contaminated. If I clean my hands, I will not transfer it over to the patient. But say I don't know, I just walk out the door and I don't clean my hands, and then I go and I touch a surface, an ultrasound, but then someone cleans that ultrasound, that can prevent transmission from happening. Or if it gets all the way to the next patient, but their portal of entry is protected. So for example, they have a central line, but there's a dressing on top of it, it prevents it from getting in. So at any point, you can stop that transmission event from happening, and all of our strategies are aimed at multiple parts. It's kind of like a Swiss cheese model. You want to make sure that you hit everything so that you prevent that transmission from happening. Now, the reservoirs are what we focus a lot on. So I'm going to talk about 3 types of reservoirs. We have the human reservoirs, and we're always, as clinicians, focused on that patient. Sometimes we're focused on ourselves or the patient's visitors and other people who come into our facilities, but that's just one reservoir. Now, you are not worth your salt in ID if you're not looking and trying to connect the animals to the infections. So afterwards, if someone wants to come and tell me what these different animals would be transmitting to people, I'm happy to see if you get 5 out of 5 right. But there are animals out there. And animals, just like people, are traveling all over the world, and within 24 hours, they can be anywhere, and they can be at the doorstep of your clinic. And then there's environmental reservoirs. And this, I have to admit, it wasn't until I was well into infection control, not just ID fellowship, that I appreciated the environmental reservoirs. I'm showing you cooling towers here, the sinks. I'm showing you ultrasounds, and if you look really carefully, there's some bioburden attached on that ultrasound that wasn't cleaned, and an endoscope. And it really, because in clinical training, you're not so much focused, you're focused on the patient, And that's like your primary goal is like, just make sure I do the right thing for this patient. You're not focused about everything else that's around you that puts your patient at risk. And you've got water, and you've got biofilm, and you've got the fungus among us, is what the ID docs say. It's out there. So that's the heavy slide. Let's start with number one, hands. Okay. Patients are a reservoir, and then the infections can get out of those patients or off of those patients and transfer via hands, equipment, and supplies. This is a case from Florida in 2020, so it was around the middle of the first year of the pandemic, where an organism called Candidozyma auris, and those of you who are into ID will know this as Candida auris. They just changed the name, but fortunately the short name is still the same, so we don't have to like redo all of our papers. C. auris, it's a multi-drug resistant fungus. It colonizes the hands most commonly, but other skin. It persists in healthcare environments like for months. So it's out there, and it resists routine cleaning. So the normal products that you would find in a healthcare system. So I don't know if you guys have purple wipes, but the purple top wipes will not kill Candida auris. And it can cause significant morbidity and mortality. So in July of that year, the Florida Department of Public Health heard about 4 cases on a single unit. And while there's a lot of Candida auris right now in Florida, I'll show you a map in a second, 4 on one unit in a short period of time sets the alarm bells off. There's got to be something going on here. So in response, they did what's called a point prevalence study. So they basically did swabs on all the patients. And lo and behold, and this is something that happens in infection prevention, if you look, you will find stuff that you're looking for, and you're usually going to find stuff that you were not expecting. But in this case, half of the patients had Candida auris. And just to put that in perspective, it's still a very rare organism, and it's not part of what the normal flora would be in a patient population. And a subset of these patients developed severe clinical infections. And just another framework, the case fatality rate, if you get an invasive Candida auris infection, is like 30 or 40%. So it's pretty serious. So how did it spread? They deployed people to observe what was going on in this unit. And what did they find? Bad practice, bad practice. The staff were wearing multiple layers of PPE. They were not cleaning their hands. They were putting the sanitizer on the glove. No, 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 don't do that. That doesn't help. Reusable medical equipment was just not getting cleaned and disinfected between patients. They like roll an ultrasound in from one room to the next, and that would spread contamination to the patients. And then lastly, those clean supply areas that are outside the patient's rooms, they were going through them with the gloved hands. The gloved hands have the Candida auris and other sorts of things on them. Those supplies are then used on the next patient. So that's how that transfer happened from the reservoir, the patient, from the hands of healthcare workers and the equipment. So what does Candida auris look like in the United States, or I should say Candidozyma auris? This is what it looked like in 2016. Okay, I'm sure whenever I'm looking at a talk, I look for Massachusetts. Keep your eye on Ohio there. I'm going to show you what it's like today. That's where we are. So things have changed. There's certainly an increase in the amount of C. auris. We're screening more for it. There's certainly hotspots around the country, and Ohio is in the hot-ish area in terms of the amount of C. auris that's out there. So why is it that we have so much transfer of pathogens and the hands are often implicated? So this number is real. 40% of the time is when we as healthcare personnel are cleaning our hands when we should. And that seemed like when people see that number, they're like, oh, it's not me. That can't be. It's like, it is true. And study after study has shown it. And I'll show you one of those studies. Now, I think all of us would agree that if we're going to go to the walk-in clinic or to the hospital, or our parents or any other people in our family are going there, we expect that 100% of the time people are cleaning their hands. And why is it so important? Well, 40 to 60% of transmission is contact transmission, and the majority of that is happening through our hands. In a typical interaction with a patient, you're touching them, you're touching the room, you're touching so many surfaces. They've even done studies, time-lapse studies, and there's hundreds of opportunities for when you are going in between the patient and other things in the room. And that's fine as long as you clean your hands and then you break that chain of transmission. But we don't clean our hands often enough. So now I'm going to show you a video, and I'll do a little voiceover. So this is from UT Southwest. I think it's the chief of ID there. He wouldn't do this on a normal day, but this is a typical clinic situation. He goes to see the patient, shake their hand, and what if you could see this? And so this is kind of a mental picture of what's on the patient. And typical things we might do, examining the patient, decides to go, in a moment, he'll go get gloves and he'll do the fail that everyone does where they don't clean their hands before they get the gloves. And so now the glove box is contaminated for the next patient. Goes in, takes the gloves off, feels like the gloves must have protected me. I'm not gonna wash my hands, walking right past the sink. Now going into the charting room where he's gonna use the computer, unsuspecting, transferring whatever was on the patient in the room onto the keyboard. Then he's gonna take it one step further here and thank his colleague. Oh, I'll shake your hand. Now you can take it to your patients. And then I think at this point, another colleague comes and sits down at the computer. They also have no idea that there's been contamination there. Here's the statement, 80% of infections spread by hands. They get called in to go see the next patient. No hand hygiene. If they'd done hand hygiene, this would not happen, but they're gonna transfer over that drink with the contamination. So that's how transmission happens. We don't see it, right? Because we can't see the microbes, but it is happening all the time. Okay, so how bad are we at hand hygiene? This is a study that was done right around here. So there was a preclinical medical school student who was trained to do hand hygiene, and this is 6 weeks in 1995. And you'll say, why are you going back so many years? It'll be known in a moment. This student was unknown to staff, and that's really important because if you know that someone's observing you, you're gonna behave differently. So this was a covert observation. They found that 30% of the time, hands were being cleaned when they needed to be. And there was no difference on shifts, but there was variation by job. So I just want to point out that in this case, the residents did much better than the attendings. They were at 59.2% versus attendings at 37.4%. Now, this was a great phrase from the discussion. I'll just read it. Despite the well-known benefits of hand washing and the coaxing, cajoling, threatening, and pleading by experts in infection control, healthcare workers still neglect to wash their hands. And who is the first author of this paper who probably coaxed and cajoled and threatened and pleaded? It's your own, right there. I'm not sure who the med school student was in this one. I think it was John Hazy. I don't know if that name rings a bell in this community, who was a pre-med or student at the time and did those observations. So have we improved since 1995? Not much. I think it's because humans are humans, and humans are going to do what they do. This is a systematic review and meta-analysis looking at data published from 2010 to 2021. So they found 49 different studies, or there were 105 studies, 5 cluster randomized control trials, 52 non-randomized studies of interventions, and 48 observational studies. When they pooled the compliance across physicians and nurses, it was 45 and 52%. So we're right around that number that I gave you, around 40% is what the literature will show. So one thing people have been interested in is, like, can technology help us? There has to be a solution to this perennial problem that we're just not cleaning our hands. This was a prospective intervention of an electronic hand hygiene monitoring system. So these are systems where you're wearing your hospital badge, and there is a way that it can tell your proximity to the hand hygiene dispenser. Sometimes there are different versions of this, assessing how much time you spend by it, and everything is mapped out so it knows when you should be doing hand hygiene. In this study, they collected data from the baseline, and then they started giving the results back to the clinicians. In the first phase, it was like groups. It would say, okay, nurses generally on unit X, this is how you're doing. And then they added the physicians, unit X you're doing. And then they started giving individual feedback. So once a week, you get your own report as to how many times you did hand hygiene when you should have. So like the proportion compliance. So they looked at the compliance, but they also looked at a secondary outcome, which is healthcare-associated bloodstream infection. So if you do hand hygiene better, we would expect, and we know from the literature, that healthcare-associated infections writ large should decrease. So here is the figure. So on the y-axis here on the left is the hand hygiene compliance, so like 20%, 40%, 60%, 80%. Sadly, we don't get above 80%. On the right side here, you're seeing daily hand hygiene opportunities, because there's like thousands of opportunities a day to clean your hands. And then you have the time on the x-axis. And you can see that you start getting, by giving this feedback initially in group, you start seeing improvements in hand hygiene. But when you get individual feedback, you get much higher. And so I think that kind of immediate feedback where you're learning about yourself and you're saying, well, I think I'm good, but I must be missing opportunities. I'm only at 80%, really prompts people to do better. Because otherwise, yourself, like you don't perhaps have the awareness of what is going on, and you don't know how you compare to your peers. So this could be a very effective tool, and many institutions are exploring that. This is what they found on bloodstream infections. And basically, they found a significant decrease to the point of 0 during the intervention period. Now, I don't know how long this has been sustained over time. This is certainly a very exciting outcome. So these are the practical next steps for this group before we turn to sinks and drains, which is there are lots of opportunities to clean your hands. There are some key moments when you need to clean hands. And you saw how contaminated that environment got with the green paint. Consider the environment contaminated. Don't freak out about it. Just clean your hands when it's appropriate, and you can interrupt the chain of transmission. The last, number 5 here, is one I do want to highlight, which is before and when taking off gloves. There is something that when we put on gloves, we think probably magically that everything's clean. My hands are clean. It's not true. 1, they become contaminated very quickly. 2, there are microperforations, and the act of removing them contaminates your hands. You saw that in the video. So it's incredibly important to do hand hygiene irrespective of when you're using gloves, which brings it to the next point, which is gloves are not a substitute. Putting on gloves doesn't magically clean your hands. It doesn't protect your patients from the contamination that was on your hands, because by putting them on, you basically have contaminated the gloves. People tend to use gloves too much in many circumstances where they're not needed. So using gloves when you're not supposed to use them can actually undermine hand hygiene, and it's also wasteful. So make sure that when you're using gloves, when it's appropriate, and you're doing hand hygiene again before and after removal of the gloves. And lastly, role modeling. So everyone here is a role model. Multiple studies that I have not shown here have shown that, like, if there is someone who is doing hand hygiene, people around them will do hand hygiene more. So in all of the, many of you are med school students or pharmacy students. As you move forward, you all will be looked to as a role model by your peers. And if you are doing this more, they will do it more. So it's incredibly important to be a role model. Okay, we're going to turn to sinks and drains. Many of you may feel like this by the end of this talk. And when I've shared some of this knowledge with my colleagues, I will often get texts like, I'm not sure where I should put my toothbrush near my sink. Tell me where's the safe place. Okay, so the next case or outbreak investigation we're going to go to is in Austria. And this is where a patient was transferred into a hem-onc unit. They were known to have a really resistant organism. This was a KPC, so a carbapenemase producing Klebsiella. So they knew it, like coming into the unit, they put the patient on contact precautions. It wasn't like an unknown, we didn't know this patient had this particular organism. But then they noticed that there were more cases. And so over a 2-year period, they started seeing more and more cases of this organism. Interestingly enough, they were already doing environmental sampling. This is not a common thing to do, and they had not recovered this organism from their standard environmental sampling. But they had started reading about sinks and drain issues in the literature. So they said, why don't we add drains and hand washing sinks and showers to our surveillance for environmental sampling? What did they find? So there were 10 additional patients who had this same organism from this initial patient, and they sampled the drains from the hand washing sinks and the showers, and they found this organism. So 1 patient, 1 ward, multiple transmissions to other patients. So I used ChatGPT to make the cartoon, because in 2013, they couldn't have possibly used ChatGPT to make a cartoon to explain how they think transmission happened. So there are some weird things in the cartoon. I noticed afterwards one person has 2 arms, but that happens with ChatGPT. So first stage on the left, patient with known colonization shows up. They're wearing the PPE somewhat appropriately. What they think happened next is that the patient's KPC was in their body fluids, and so that got poured down the drain. Or the patient was washing their hands or using the shower, and so the organism kind of went into the drains. And then unsuspecting, they have some materials here right next to the sink, and I'll tell you more about what happens in the sink, but those materials got contaminated and then transferred to these patients unsuspecting. So they implicated the sinks and the drains in the transmission. So in fact, there is a growing body of evidence that the sink is a reservoir. So we talked about hands as reservoirs. Sinks are reservoirs, and there's been confirmed transmission across multiple studies. That study is included in this systematic review, and they looked at the water reservoirs, and drains and drainage systems and sink surfaces have been implicated, and they have used advanced methods of sequencing to say, yeah, the infection in that patient is the same thing that came from the drain, and it was transferred between the patients through the drains and sinks. So how does this happen? It's us. Just like the hands, it's me, I'm the problem. Sinks, it's us. And I'm going to explain to you sink anatomy. So you're all doing anatomy, or you've done anatomy. We're going to do sink anatomy. So this is a sink, a typical sink. Most of us are just focused, if we even look at the sink, on the basin and the faucet and the handles, right? We're not looking beyond, underneath the countertop, but that's where the action is. So that drain pipe is called the P-trap there. If you tilt your head to the right, you'll see it looks like a P. That P-trap has what's called the water seal. There's a little bit of water there, and the water there is on purpose because it forms a seal, and that helps like the odors from the sewer from coming up into the room, right? So that's a good thing. We don't want to smell all the stuff that's down there. The flip side is that it's stagnant water, and the inside of that pipe is like a perfect breeding ground and establishes biofilm from organisms. And then that's what's happening. But then you're thinking like, well, how does it get from the P-trap into my patients? And that's really interesting. We do a lot of, we augment this problem because we put a lot of stuff down that sink. So we're sticking nutrients, like we might waste, I don't know, ginger ale, you might pour that down there. You might pour down some old antibiotics or chemicals might get put down that drain. People will wash their hands, and whatever's on their hands, those microbes go down. Or in the picture, the ChatGPT picture I showed, they were pouring the body fluids down the sink. And what happens is it becomes an incredible breeding ground, and those organisms forming biofilms start growing up that P-trap into what's called the tailpipe, all the way up to the strainer of the sink. But at that point, it's still in the sink. So you might be wondering still, how does it get to my patient? Okay, we turn on the faucet. That water hits the strainer, which now is colonized with all that good stuff, bad stuff, the organisms, and it splashes. And it creates a splash zone. It's about 3 feet. And all of those clean supplies, you can see that I've put, this again is a ChatGPT cartoon I made, all those things, your stethoscope is now contaminated. And you don't know this, but then you take that Foley catheter kit, you take those gloves, you take those gauze things, and you use them on the next patient. And that's how the transfer is happening. They have done super fancy sink studies. There is an ID doc at UVA, Amy Mathers, who's also Clin Micro. She has what's called a sink gallery, and they set up all these sinks to do these really amazing experiments in it. And in this case, they inoculated the P-trap with an E. coli, and they put like a fluorescent tag so they could visualize what was going on with the E. coli. They put some nutrients down there, just like in that little cartoon, they're putting all the stuff that we normally put down the sink. And then they tracked how far it grew. And by day 7, it grew all the way up that tailpipe and was at the strainer. Really fascinating. But that's just one sink. Now the sinks by the plumbing are all connected. There's all this crazy plumbing underneath, and these sinks and drains are all connected. So they also showed in this sink gallery that they inoculated the 5th sink. So there's sinks 1, 2, 3, 4, 5. They inoculate sink 5, and then they can recover that E. coli from sinks 2, 3, and 4. So it kind of goes through the plumbing of our, dental clinics, our, urgent care, our hospitals. It's making its way through the plumbing system. Then they, to establish what that splash zone is, they set up all these plates, they turn on the faucet, and then they document the splash zone. So really awesome, but a little bit scary, like we didn't know that all this was happening right as we were washing our hands. Like you told me I should wash my hands, Erica, but now you're telling me that I'm creating a splash zone and contaminating things. So people have tried to fix this. They poured so many different things down our drains, tried mechanical disruption, heat, and everything, you name it. Nothing has really been successful. In some cases, it's actually changed like the ecology so that you get different, still bad organisms growing in your pipes. These are two recent papers I'll cover that looked at using a foam disinfectant. And the reason they were trying to use foam was because it would kind of stay in place for a longer period of time versus the dilutional effect that you get if you add a disinfectant down a drain where there's water. They had a really great setup because it was a brand new building. So fresh plumbing, nothing in there to start. This was at Duke, and they had basically a new unit that had 30 rooms. So there were 30 sinks that they could randomize. So not randomizing people, they're randomizing the sinks. The intervention sinks got this foam disinfectant 3 times a week, plus whatever routine surface disinfection that would be kind of your normal standard of care. And the control sinks got just the standard of care. They took environmental samples from the surfaces, the drain, and the P-trap, and what they were looking for was how soon do they detect one of these epidemiologically important organisms. They also looked, since they were looking at the sinks and putting the foam down there, how often when they looked at the sinks did they find that people were putting supplies and stethoscopes and all the stuff that I've told you should not put in the splash zone in the splash zone. So the bad news is 29 out of 30 converted. So they went from brand new, beautiful plumbing just put in to having these epidemiologically important organisms. Now, what the foam does appear to have done is it delayed how long it took them. So like you got a little bit more time before you converted over to having the bad bugs, and you recovered them at a frequency that was less than in the standard of care. 93% of the observations, they found stuff in the sink zone. I'm just showing you here the proportion in the intervention sinks in the tailpipe and P-trap was about 4% of samples were covered those organisms versus 39 and 24% of the others. So disinfection, like shoving stuff down the drains, that's not going to be the solution for now. I'm sure people are working and they are working on new methods, but we really need to focus on the sink hygiene. So how do we use sinks in a way that is still safe for our patients? The second study said, okay, foam may not be good enough. Let's try foam plus. So this was 30 NICU sinks. There were 3 interventions and they kind of layered them. Group 1 got just foam like the other study. The next group got foam, but they did some mechanical cleaning to try to decrease that bioburden and biofilm. The third got foam, drain cover replacement. So replacing that drain cover sequentially. And then the last one got all 3, and that was compared to the standard of care, which was routine disinfection of the surfaces. They were looking at bacterial colony counts from the sink drains, the faucets, counters, basins, and drain covers. And they looked at day 0, so that's a starting point, and then days 1, 3, 5, and 7. At baseline, you can see the types of organisms that should not surprise you. These are water-loving organisms. You see the Pseudomonas there, and they're highly contaminated at baseline. Again, this is not like Duke that had brand new plumbing. This is a regular NICU. The triple intervention had the most bioburden reduction. So yay, hitting it on multiple fronts. However, recolonization to 50% of baseline happened by day 5. So like the bugs are very smart. The biofilm is really tough. So again, disinfection is not going to be the solution. What I'm showing here are the day 0. So they all start with all that baseline bacterial contamination. The green line on the top is just the regular standard of care. So I think that initial decrease is like they clean the surfaces, they do their regular thing. All the other ones have some decrease, but you can see very quickly they start climbing, and it's the light green, which is the foam mechanical cleaning and changing the cover that gets you the kind of the lowest recolonization. So again, you need to focus on the sink hygiene. So how do we live with the fact that we have a really intractable problem and we as humans keep not seeing the risk and putting all our supplies next to the sink? So there's something called engineering controls, and you all may have seen this inverted triangle. This is a rubric that talks about the hierarchy of controls. What are the sorts of things that you can do to reduce a risk? In this case, the risk is transmission of an infection, but they use this in all sorts of industries. So eliminating the risk is great. Like if we did not see patients in a hospital setting, we would eliminate this risk because we wouldn't be there to cause a transmission event, but we can't do that. There's a category of these interventions called engineering controls. And I love engineering controls, and I put a heart there because they don't rely on humans to work. And we are unpredictable in some ways, and we're also very predictable in other ways to not do the right thing. Our focus is on that patient in front of us, and it's too distracting to actually focus on some of the risks that I've shown you. So what are some of these engineering controls that you've already seen them, but you probably didn't recognize them as such? So the first thing is, have you ever been annoyed when you've got all this stuff in your hands and there's a sink with no counter? That's an engineering control. We love sinks like that because you can't put stuff in the splash zone. Now people try, they'll put stuff right on that little counter edge, but there's a point to this, which is let's not create a counter within 30 inches, which is that splash zone, in order to prevent contamination of supplies, because we know people are going to use the sink. Another engineering controls is do a sink with an offset spout so that it doesn't hit directly to the strainer, and that can reduce the amount of bioburden that gets kind of sprayed. We can get fancier. These clear things are called splash guards. So you may see these splash guards, and those are intended to basically physically create that barrier so you can put your supplies on either side and you don't have to worry about them getting contaminated. So those are very popular. You can get even fancier. So you see the handles of these are called wrist blades. I see people using wrist blades with their hands. That's not the point. You're supposed to use them with the wrist blade because that way your hands are not going to get contaminated. Or pedals. Pedals are great because your hands aren't getting anywhere near the sink or the sink faucet and handles. So those are engineering controls. If you are really interested in drains and sinks, there's a very nice podcast where the authors of 2 of the papers that I described are on, and they're talking about their research, and I highly recommend it to you. Okay, so the next 3 concrete actions. You will be out there and you'll be working in clinical situations, and you don't want to be the person contributing to that cluttered and environment. You don't want to be putting your supplies next to the sink. And when you're out there and you have infection control teams that want to help you design your spaces in ways that actually help you do the right thing, please work with them and have an open mind. Don't put your supplies or your stethoscope or anything within 3 feet of that sink unless you've got the splash guards. And I would definitely support all of those engineering controls to limit the risk to patients. And then lastly, I think this is a really interesting thing to teach your colleagues about. This is the kind of thing you might talk about and open someone's mind to the risk around a sink that they probably, I'm going to assume you have not learned this yet in medical school. I didn't learn this till further on in my life when it became very clear from the literature that this is a major risk to our patients. Okay, lastly, this you probably have never learned. If you have, I want to know where you learned it and congratulate your professor for bringing this up. The sink that I talked about there, that's part of the environment of care, but I want to zoom back and think about the big environment of care, which is the physical facility in which care is being delivered, either a dental clinic or a big hospital or a small clinic or an urgent care. The buildings, they vary by age. This is a picture of my home institution at Mass General, where you have buildings that range in age for 200 years. Like my own office, fortunately not providing any clinical care there, is from 1811. And then we have buildings in 2010, and we have one that's about to open up. So a huge range of building age and code that was established during that time. They have to be managed. There's construction happening all the time. The choice of the finishes, are those finishes porous? If they're porous, how are we going to clean and reduce the bacterial contamination with those surfaces? And the design of the space. If you put the sink in a corner, is anybody going to go to that corner if the door is that way? No, they're not. You can make the design in such a way that it either promotes infection prevention or it actually works against you. There's also all the equipment and systems that are in the hospital, in the clinic. And these are your HVAC, your water management. In dental, and hopefully there's some dental students here too, the management of your water lines, incredibly important. There have been outbreaks associated with those water lines and specifically mycobacterial infections. And then all of us are working in these environments ourselves. So I'll close out with a couple of these interesting outbreaks related to the environment of care. So linens, the sheets and the blankets that we give our patients. In 2021, the Arkansas Department of Public Health was notified by a hospital that they had a cluster of mucormycosis cases in a hematology population. Now, this is the population that would get that infection. However, the number that they had was much higher than previously. You can see on the right, this is the incidence per 100,000 patient days. In 2018, none. In 2019, they had a few. In 2020, it's double. So something is going on. They started looking back and doing an epidemiological investigation, and a few things stood out. Half of the cases were cutaneous, so skin infections. So that was a little bit of a clue as to where the reservoir might be if it was causing infections in the skin, and that was the location of the inoculation. Just going to put that out there. But there were no common patient rooms, medical products used on the patients, or relevant medical procedures. Now, they broke this down by different units. So you'd say, okay, is this a unit-based thing? Is there something going on the hematology unit? And in fact, there wasn't. They had these cases in one of the neuro ICUs and the surgical ICUs. Now, when these things happen, our teams, infection control teams, deploy and we start looking for things. And we will always find opportunities for improvement. They did see dust. They did see some supply issues with management, but because this was so widespread, they started thinking about the laundry and what was happening with the linens. So they went to the linen place. It was an off-site linen facility that had been accredited as an official healthcare laundering facility, and they found a lot of stuff that you don't want to find in your healthcare linen laundry facility. Substantial dust and lint accumulation. The soiled and clean sides of this facility were only separated by an air curtain. No. There was no HVAC to speak of. They basically left the windows open and the loading dock open, and there's like just fungus right out there in the environment making its way into these clean hospital linens. And then to add insult to injury, infection control hates fans, just so you know, it's a pet peeve because that just blows everything around that you don't want to be, bringing up all the dust and moving things around. So those oscillating ceiling fans were like ongoing, and they were actually in the place where that clean linen was being dried, folded, and stored. It got worse because when they got to the hospital, they observed a lot of the covers that were supposed to protect those linens, if they were clean, were torn, and they were left on the loading dock for hours because there was no place to store them, and there was visible bird droppings and dust, and the linen itself, not surprisingly, based on what was going on at this linen place, often looked dirty. They did sampling, and 3 of 4 of the linen carts had at least one linen that was positive for the mucorales, and 18% of the samples from the linens were positive for the mucorales as they entered the hospital. So this was definitely coming in from the outside. Another outbreak, this is in England. This is England saying, okay, we see that there's increasing C. auris. I showed you that map. Let's see what's going on in our institution because we've only had 1 or 2 cases a year. And when they looked back, they actually found they had 9 total cases, but 8 of them had been linked to 1 unit. And so they're thinking, what is going on in this unit? So the prior outbreak, no unit association. This one had a real unit association. Here's the epi curve, and you can see in that kind of peach cover, those are the singleton cases over the period of a year that were associated with this neuroscience ICU. So they start screening. They did like what that Florida DPH said, start screening. And they did screening once and then weekly. And the gray here is all the screening that they did, and the orange is all the C. auris that they kept finding. So they started trying to figure out what's going on. And what they did find is 70 additional patients who had C. auris, 94% of them to that same neurosciences ICU. They found that they had been using reusable axillary temperature probes. They tried to do the cleaning and the disinfection, but they only stopped the new cases from occurring when they just removed them and went to disposables. And that's what they did. And so you see the rest of this epi curve, they remove them around April of 2017, and then they just get rid of them entirely and the outbreak ends. They then did sequencing, and this is why it's a New England Journal paper, because they sequenced and they matched the patient isolates to the ones from the reusable medical equipment. I mentioned construction. Construction's happening all the time. Like when you're going to be in your clinics, it might be as simple as they're pulling a ceiling tile out of the ceiling, or it could be as big as a new building going up. But construction raises the opportunity for there to be dislodging of dust and other sorts of disruptions. This was a review of the literature looking at fungal outbreaks that have been published. They found 49 studies that met inclusion criteria. And you can see over these 5-year periods, it looks like it's decreasing at the end. There's 2 hypotheses for why there were fewer studies published. One is that we got better at infection control. I do believe we recognize the risk more and there's more attention to this. But I think the other piece of this is a publication bias, that after a while, who's going to publish the repeat fungal outbreak because we already know that these things happen. So there's a little bit of both, that it seemed to be decreasing. The majority of patients impact, and this is really important, and these are the hematological patients. So these are, if you think about the chain of infection, that last bucket was susceptible host. These are among our most susceptible hosts. So given an exposure, they may be more likely to actually have an infection than a non-susceptible host, someone with a more intact immune system. And in fact, the majority of the patients here are identified of that population, and the case fatality is very high. It's like 48% in this population. So there are basic things that we do for infection prevention, and they're listed here, but a lot of this has to do with actual infection preventionists who assign a risk level to every construction project that's happening in a hospital or a clinic. Based on that rubric, certain interventions have to happen in terms of containing it and making sure that we are doing everything we can during that construction to prevent that risk of invasive fungal infection from reaching our patients. And then I'll stop, this is my last study and then I'll close. There's a lot of work out there on sustainability, which is incredibly important. There's a flip side to this sustainability, specifically around water. So we talked about all the drains and the pipes and stagnant water. This study looked at when I said leads to infection, because this is a hospital that had built a new tower that had attained a silver LEED certification. In order to attain that, you need to have a 20% reduction in your water use. 20% reduction leads to low flow water states. So I'll tell you what they found, and this is at a very large pediatric hospital. So they did a retrospective review of all their cases of Mycobacterium chelonii. So Mycobacterium is water loving. They had periodically seen some cases, but they started seeing more cases after this new building opened up. And if you look at this figure, the epi curve, the building opened in September, so that's the third quarter of 2021. Before that, they'd only had one case that year, and it was fully occupied by the end of the year, and they already had 2 cases. And it continued through 2022, and when they started getting concerned that we might have a problem. They did a lot of molecular testing, both of the environment and of patient samples. They found 16 cases, and again, it may seem like low numbers, but this is an unusual organism, and to have this number in a short period of time is very concerning. They did not have any spatial or temporal overlap. So remember that outbreak that we talked about where they saw them in all different places? It's a similar sort of vibe. That must be something that is bigger than a particular unit. In the end, and they did like an extensive, beautiful investigation, they found 2 things. As they were building that tower, a second tower that was attached to it had a lot of construction. And they think that during that period, the endemic biofilms and all that plumbing got disrupted. So there was like an increased amount circulating in the water. That combined with this low water flow system was like a great breeding ground for the mycobacteria. And that ended up in all the dispensers and the sink faucets and the drinking fountains. And that transmission then happened through all those water sources. So it is a cautionary tale that when we do interventions that have one goal, they're trying to mitigate the risk to the environment of our water use or other things, we have to understand that it could introduce other risks and then appreciate those and try to figure out, okay, where's the balance and what can we do to reduce that? So my take homes are 3. The first one is clean your hands. Make sure that people around you understand the importance of clean hands. So much of what we do involves touching our patients, touching the environment, that it is just so critical that you perceive the risk and do something about it. Sinks and drains equal risk. Hopefully you have an appreciation for the sink environment, and how important it is to have that sink hygiene. And maybe some of you will be inspired. I'm thinking about the dental students too, just because of the dental unit. Water lines are so really tough and interesting and challenging to do research or investigation in this area. There's so much to learn. And last is, we're so focused on our patients, and that's absolutely what we should be doing. But to kind of step back and remember that we're working in this environment, the environment of care in which we deliver all of our wonderful care can actually work against us or can work for us. So we should do as much as we can to make sure that it's working for us and not against us and against our patients. And I just want to say thank you. You guys were a great audience, and I'd love to take any questions in the few moments that we have.
Thank you very much. That was great. So we'll take questions for people in the room line up at one of the two microphones, and then we'll take your questions there. For people on Zoom, put the questions in the chat, and we'll read them here. Dr. Ping. Dr. Zhang? Dr.
Oh.
Don't know why. Oh, it works. You know, it's very, very exciting talking, and then very informative and entertaining. Thank you very much. You know, frequently I don't know whether or not anybody else said, frequently I see our medical care providers, they wear their PPE, especially in those dresses with a colorful color, like a blue color, green color, or purple color. They wearing those kind of like PPE dresses from their working site, like a clinic and a hospital, and they walk in the street, and then walk to the nearby coffee shop to grab a cup of coffee, and then they might be, you know, stop by the nearby diners and the cafeterias to grab their lunch or even eat their lunch with them. And also, like, you know, one typical case is one of my friends run into my house wearing that kind of like blue dresses, join a group of my friends for the private party. So for the hospital infection control point of view, is this can be a concern or it doesn't matter?
Okay, so
Thank you.
the attire question, this is a hot question. Let's break it up into certain things. So you know, our clothing does become contaminated. One of the reasons we want people to not have clothing that is like hanging on and touching the patient, or when someone's on transmission-based precautions and you're wearing a gown, you're intending to decrease the bioburden on your clothing so that you're not then transferring it to the other patient. There are certain circumstances where it is such a high risk because the activity is being conducted. So think of the operating room and procedural areas. You know, there's some surgeons among us. There are restricted zones. And in those restricted zones, if you are wearing clothing from the outside, you have to put on hospital laundered, hopefully not in the linen facility that those linens were in, but hospital laundered scrubs, because it's a restricted zone. And the reason it's restricted is that we are opening up sterile body sites and we want to restrict reduce the risk to those patients. Outside of that, I think it is generally, it's not great, but there's no direct link from kind of wearing those out in the community, except I think in those risk areas where there's a potential risk to that patient. Other things we counsel people on is just basic kind of common sense. So people will wear like fleeces and they have kind of covering their hands. And it's like, you cannot clean your hands appropriately when you're wearing those. You can get contamination in your wrists. In some medical cultures or in some countries, they do bare below the elbow for that purpose to reduce the risk. So I think the way to, just a long story short, there is potential risk in the highest risk areas. It's quite controlled. And so that sort of outdoor clothing cannot come into those locations. In other places, it's best to use your common sense and then use barriers if there's the risk that those clothing can be contaminated by splashes or sprays or other sorts of things in the care that you're delivering.
Thank you very much.
Dr. Dong.
Great talk. Thank you so much. You show some data for the Candida aureus. The prevalence increased significantly during the past 10 years in the United States.
Yep.
I was wondering, is there a similar pattern worldwide? And also, in addition to this bacteria, this pathogen, are there other pathogens that show the similar pattern?
Yeah, so with Candida auris, definitely an issue worldwide. You know, it's been known since 2009 when it was, the reason it's auris is it was identified from a culture from the ear of a patient, I think in Japan. So that's the auris part of the name. There's two parts about the increasing incidence. There's definitely been some pockets of a lot of transmission, mostly in long-term care, nursing home sort of facilities. And that you see that a lot in Illinois, Florida, New York, those areas. We are also doing more screening. So there's an element of both, I think, better case identification and these transmission events happening. And that is it's considered a big issue in the United States, but also in other countries. You saw the UK and in Europe. So I think it is a worldwide sort of issue that we're having. Writ large, antimicrobial resistance continues to be a bigger and bigger problem. And that is a worldwide problem as well.
Thank you so much.
As we've seen, both increased levels of infiltration from private equity into healthcare spaces, as well as federal budget cuts in the healthcare space and the effects they've had, for example, in emergency departments and underserved and rural areas. What effects do you think, if any, have those things had on things like immune disease, infectious disease control in the United States, if any?
Oh, that's a big question. So I don't know the immediate impact of that. However, our ability to respond to infectious disease threats depends on having really great surveillance, having robust public health, as well as those partnerships with the healthcare facilities that are have the expertise and have the right people, trained people to be able to do that. So to the extent that there is any decrement in our overall surveillance capability or that interactions that we have, on a very frequent basis with our public health colleagues, there could be an impact. I can't put a number on it right now, but certainly infectious diseases isn't going anywhere. If anything, with the way the world is moving and with the amount of cross travel and we haven't even talked about animal reservoirs yet. It's certainly a busy time in infectious diseases.
Okay, it's 1 o'clock. So those of you that have class, you're welcome to leave. Otherwise, and if you don't have class, you can stay and we'll keep going with the questions. So if you need to leave, leave. Go ahead.
Hi, so this is more something that I'm just kind of curious about, because I am very in on trying to keep up the best hygiene as possible, especially in the clinical setting. So when you talk about the splash zone that's 30 inches, is that more just referring to surfaces? Because would that also be sort of contaminating our arms and stuff hanging around our necks, our stethoscopes, or would it just be more pertinent to surfaces?
Yeah, that's a great question. I mean, it's a trajectory. But most of what we think about is the surfaces there and the kind of deposition on those surfaces. But certainly, if you have washed your hands, you don't want to then go touch the faucet because then you kind of that is contaminated. So yeah, so that's a way to think about it. And this is not meant to freak everyone out. We're all we live in an environment where we're covered with organisms. There's organisms everywhere. It's more about thinking about the things you can do at really key moments to prevent the adverse outcome that we're trying to prevent. So hopefully that answers your question.
Thank you. That does provide a little bit of comfort.
Dr. Chilian.
Copper has many antibacterial qualities. Do you know of any studies that compare hospital settings where they use typical PVC plumbing versus copper plumbing in terms of outbreaks?
So there have been studies looking at copper on surfaces like the bed rails and things like that. I don't know about it in the plumbing itself, so I have to look into that. The plumbing, yeah, I don't know. That would be an interesting one to look at. Copper's pretty expensive right now, so I don't know if that would break the bank, but.
I wonder if copper just in the P drain area would be helpful.
Yeah, it may. That's something to look into. I think the P trap itself is both the stagnant water, which the copper's not going to help a whole lot with. It's also the surfaces and the ability to kind of form biofilm. So to the extent that you have a material that is less biofilm forming, it might stand to reason.
Okay, thanks.
Yeah.
Yeah, I'm going to cut it off here. Dr. Corbett, we can wait, we can wait for you. Because I want to give everybody the time to wash their hands before they go back to the next class. Let's thank our
Wow. Wow.